Go ahead and get started. Hello, welcome everyone to today's Thrive Court training topic, evidence-based practices, treatment, rehabilitation, and support. Today's training has been developed and is being presented by Community Alliance. Today's session has been approved for 1 hour of CLE credit. There will be a link in the chat for a certificate of attendance that you can download and save for your records. And this link will appear towards the end of the training. This session will be recorded and posted on the Court Improvement Project's YouTube channel. This is the 6th training in the series. And so if you've missed a topic, you can find all of the past episodes on the YouTube channel as well. Our presenters today are Stacy Ring and Jeff Wiebel with Community Alliance. Stacy is a licensed independent mental health practitioner and the manager of the Behavioral Health Education and Training Department at Community Alliance. Jeff has been the clinical director of Community Alliance since 2020, and he is a licensed independent mental health practitioner and licensed clinical social worker. So welcome everyone, and I will turn it over to them now. Thanks.
Hello, thank you for joining us today. I'm Stacy and I'll be your primary presenter today, and Jeff will be monitoring the chat. So hopefully we can stay connected with all of your questions in as real time as we can get it. So I'm going to go ahead and start. And today, what we want to do is we want to talk to you about different types of treatment and different levels of care that are available for people who are experiencing mental health challenges. Is the PowerPoint showing as slides? There, okay. So today we're going to talk about the different types of services for individuals who are accessing behavioral health services, because they aren't all the same. So we're going to talk a little bit about that. We're also going to talk about even within treatment for mental health conditions, different types of medications, not an overview of psychopharmacology for sure, but the benefits of oral versus injectable medications. And then we're also going to talk about different types of therapeutic interventions that can be useful to individuals in treatment for mental health conditions, and then rehabilitation. And we'll talk about the difference between treatment, rehabilitation, and support as well. So that's something that we will be focusing on today. Okay, so in terms of recovery versus rehabilitation, that's an important distinction to make, because sometimes things get used interchangeably with these two terms. So recovery is really what the person does in their life to address whatever the issue is. So this is their unique journey that is about like the internal changes that they make in their attitudes and beliefs, possibly changing their values, as well as external changes that they might make in terms of activities, habits, things like that. Oftentimes in substance use recovery, they talk about people, places, and things. So this is about those things that they do. Since it's a journey, it's usually considered that recovery is like a lifelong process. At some points, it'll be easier and more automatic for people, but it will always be some part of their lives. And there's always the potential for setbacks or relapses. In fact, there's a common phrase that is unfortunately a reality for some people, which is that relapse is part of recovery. And so we work a lot with our clients here to not anticipate recovery, but to plan for if things would happen that would set up a series of events that might lead them back into some old behaviors, or might take them all the way back in to their addiction or to their mental health relapses. What would we do to try to put things back together, or to make it not quite so severe in terms of the outcomes for them? So Unfortunately, while we like to think of things as a finish line or getting to a goal, in recovery, it really is a lifelong process, like it is for many other chronic health conditions. Um, Next, we're going to turn to a discussion of treatment and rehabilitation. And so we're going to go to the next slide for that. Um, okay, did the slide advance? No. Okay.
Yeah.
All right. What is it not doing? Oops.
I have to click on the other screen.
Okay, let's see.
There you go.
There we go. Okay.
Yep.
So there we are. Okay. So in terms of treatment and rehabilitation, we'll talk about that a little bit more on this slide because there are really treatment, rehabilitation, and support interventions that we can use to help individuals with psychiatric needs. So treatment really is about diagnosing the condition and then providing some types of services, usually medication management and therapy or counseling services, that will help the individual to get to their goals. So in some cases, this might also include inpatient or residential treatment for mental health or substance use issues or both. Rehabilitation services focus on restoring functional skills that were lost, usually as a result of the symptoms or the condition that the person has. So, for those of you who have been with us through some of the other topics, when we talked about thought disorders and mood disorders, we talked a lot about how those conditions not only affect how a person feels or experiences reality, but also how they're functioning in their daily life. So rehabilitative services really work to address those key functional areas that are impacted by their diagnosis. And the goal is to improve their ability to function in day-to-day life. So that would be things like money management, cooking and nutrition, relationships with other people, those kind of things. And then support interventions are focused on providing ways for individuals with mental health or substance use issues to have access to non-professional supports, usually people who have been through a similar experience or have been on a similar journey that they have been, or who are able to provide key connections to communities and other supports that they might need in their lives. So we'll talk about each of these a little bit more on different slides. But in this slide, as you can also see, we have a graphic here that talks about the integration of care. One of the things that has become an evidence-based practice is this concept of integrated care, because we're all individual people going to healthcare centers, for example, to receive services. And oftentimes our healthcare services are kind of pieced out. So we have a primary care doctor in one office, and then a couple miles down the road, we have an optometrist or ophthalmologist, and then we might have a dentist somewhere else. And then different people, might have other specialties and things like that. So in integration of care, there's a couple different ways that we can do that. We can have services that are co-located. So you might have one medical building where there are different providers in the same physical building or maybe, very adjacent to each other. You also may have, so those are co-located services. Then you might also have services that are coordinated. So they may not necessarily be in the same building or the same property, but they are coordinated. So a doctor will communicate with another doctor or clinic about their patient. So there is some collaboration and coordination. And then the last option here is true integration of care, where not only do the providers communicate with each other, but they also are located in the same physical space so that they can be more accessible to each other for those coordination activities. So in terms of treatment specifically, treatment usually begins with an assessment of the client and whatever their issues are that they're presenting with. So sometimes, as we talked about in the diagnosis specific topics that we presented, the person may need, even though they're presenting with a mental health or substance use condition, may need to be evaluated for some medical concerns, because part of the diagnostic criteria for mental health and substance use issues is to make sure that the symptoms they're presenting with are not due to another medical condition. So sometimes we might need to rule out some other things. For example, it's very common in older adults to see them have altered mental status when they typically are quite clear and lucid if they have a urinary tract infection. So we wouldn't want to diagnose someone with schizophrenia or psychosis if they had no prior history and this came on very suddenly, because there really may be an underlying medical condition, whether it's an infection like that or some type of, brain injury or something else. So we want to rule out those causes. So if or when a diagnosis is made, the provider, which is usually in mental health, a psychiatrist or APRN or physician's assistant, when they make a diagnosis, then they will typically, like every other doctor, recommend a plan of care. So they'll talk about, these are things we can do with medications. These are things we can do with therapy. These are things we can do with other types of programs or supports that could be open to you. So they'll help the person make some informed decisions about what their treatment for this condition should be. And what research has consistently shown us is that a combination of medication treatment and therapy for mental health conditions usually provides the best and most efficient, expeditious outcomes for people. They get better faster. It doesn't mean that they're going to be taking medications forever or that they're going to be in therapy forever, but it means that when they're at an elevated level of severity, and they want to feel better faster, the best bang for their buck is to combine both services and for a period of time. And then once they stabilize those underlying symptoms and learn some new skills or resolve some issues that have been going on in their lives, they are typically able to move forward, sometimes reducing or eliminating one or both of those other treatments. Sometimes they will continue with medications but discontinue therapy. Sometimes they'll find they don't need the medications anymore and they can, maybe finish out some therapeutic goals and move forward. Sometimes though, the person will need maybe an inpatient type of treatment or a longer term residential treatment to stabilize those symptoms. This is usually when the person is considered to be a danger to themselves or someone else. So sometimes those inpatient stays can be anywhere from, 3 to 5 days. Sometimes they may go into a longer term residential program where it could be 30 days up to maybe 6 months. Those are much less common nowadays because they're very expensive. And they are, so you have to justify the level of care. And also for many people, they just would prefer to be at home and they may have supports that can help them be at home. But for some people, they need that residential level of care. Another consideration in treatment is medication itself. So for some people with substance use disorders, they may need medication-assisted therapies to address their issues. So this, for a lot of people, can help with cravings that they might have. So it provides a different support to the individual, giving them something that is non-addictive, but can help with some of the issues that they might be having. So some of it can be the physiological cravings that they're experiencing. Some of it can be the reward receptors in the brain that could kind of diminish some of that like impulsivity or sensation seeking. So some of those things can be helpful to individuals. Another thing to think about in psychiatric medications too is the question about oral versus injectable medications. So for some individuals, they do just fine with medications that are taken orally. For other people, though, that can be a bit of a problem for them because maybe they forget, or for individuals who are unstably housed, it's pretty easy to lose them or forget them somewhere, or for people that are living like in homeless shelters or on the street, for them to be stolen. And so it could be a better option for them in terms of being consistent with taking the medications if the medications are given on an injectable form versus an oral form. Because usually the injectable medications are good for about 28 to 30 days. So the person doesn't have to remember every day or multiple times a day. Another thing that can be a consideration in injectable medications is if the person struggles with wanting to take their medications at all. So for someone who maybe has a history of deciding to not take their medications, talking to them and getting them to look at the benefits and agreeing to take the medication once a month can sometimes be a little bit easier than trying to have those conversations every day or multiple times a day. So those injectable medications provide some benefits to those individuals as well. Now, the downside of injectable medications, there's a couple of them. Some people just don't like shots. Also, for some people, they experience a little bit of an increase in symptoms, sometimes towards the end of the injection cycle, right before they're getting ready for the next one. So they may have some breakthrough symptoms. So that can be a problem, usually addressed with giving them some oral medications to take those last couple days so they feel more comfortable. The other thing about the injectable medications is once they're given, they're given. So you can't just abruptly stop them or, take them out of the person's body like you can if you're giving someone oral medications. Because if they're taking oral medications and they develop a side effect or don't like how it's working, you can always kind of just take that away or titrate it back down and try something else. Whereas with an injectable medication, you kind of have to wait for the cycle to end. So those are some considerations with medications specifically. And then in terms of mental health counseling, that's considered a treatment intervention. And there are lots of different types of therapy. So some people say therapy and they make it sound like every therapist does the same thing. And they don't. There are different types of treatment, and different types of treatment are usually more successful with certain presenting problems. So for example, for people that have trauma, EMDR is a very common therapeutic intervention that can help people with very large trauma histories who are having a lot of active symptoms related to that. DBT works with a lot of people who have issues, like it's often used in substance use, it's often used in serious mental health issues, it's used in people who have a lot of issues in relationships with other people because it helps the person to develop really tangible skills to self-regulate themselves and to be more effective with other people in their lives. So that's one type of therapy. There are lots of other therapies that can work, and so it's really important to make sure that the person is getting a therapist trained in the right types of modalities for the things that they're trying to address. And then in terms of substance use services themselves are not all the same. So for some people, they may be seeing an individual counselor to address their substance use issues. So it's a very one-on-one type of intervention. Other people may do intensive outpatient services where they are at home or living wherever they were living, and then they come in as really kind of an outpatient visit, but it's usually about 3 times a week, sometimes a little more depending on the level of IOP. So for example, we have level 2.0 IOP here. So people come 3 times a week, and it's about 3 hours a day, and they complete about 18 sessions. And then if they do that, they're successfully discharged. Others have maybe a little bit longer or more frequent visit schedule, and may have other requirements that go along with it too. So the substance use evaluation will indicate what levels of treatment are the right for that person, where they are in their journey. And then substance use residential services are also an option. So there's a short-term residential that can be about 30 days, and then longer-term residential programs where people may stay, anywhere from a few months to 6 months as well. Any questions about the treatment, things that have come in, Jeff?
No, I don't see anything on the chat right now. I think that's a great summary. And I think the other piece I think you talked about, Stacey, is that we've shared a lot of information the last several weeks, and this is kind of, okay, now what do we do with all that? How do we help people to truly get connected into the resources and the services to make changes in their lives? And I think, as I think about our own IOP program, communication with that program is critical. There are times when a person for the mental health counselor is not a good fit, and so they need a different therapist. But I would be asking some more questions if they seem to move through multiple therapists without any other good reason. So I think that's part of this fit, and some of the work that you all have to do too, I think, is making sure people follow through on the services recommended.
Absolutely. Okay, the next type of service that we're going to talk about is rehabilitation. So treatment services are one option. Rehabilitation services are another option. And again, for some people, they may, within treatment, only want to do therapy or only want to do medications, and that's fine. Or they may opt to do neither, and they may try just rehabilitation services. That's okay too. These can be standalone things, but again, they work best and are most effective when they're combined. So, rehabilitation interventions, one of them is called assertive community treatment. It's essentially a hospital without walls. It's a multidisciplinary team. Talk about integrating care. This team has a psychiatrist, a therapist, a substance use counselor, a vocational counselor, a nurse, a community support worker or care coordinator person, and then a peer specialist. So somebody who also has lived experience with mental health issues. And they all wrap services around the person. In Nebraska, it's the most intensive community-based service that there is available for mental health services. So generally speaking, the individuals that are in assertive community treatment programs have very long-standing, chronic, severe presentations of mental health issues, and usually also will have had periods of institutionalization or extended periods of homelessness, where they've been very, very dependent on supports to help them meet their basic needs because of the severity of their illness. Also, there's this is called various things in various places, but illness self-management training, really what this is teaching the person how to understand their illness. Because yes, there may be 30% of the people on this Zoom call who might have a mental health diagnosis, but everyone experiences it differently. And so that's what this gets at, is how an individual's unique presentation of their illness is. What symptoms do they experience? When do they tend to experience them? How do they experience them? What are the things that are effective in helping them from a medication perspective or a coping strategies perspective? Who are their supports? All of those things are really focused on in this, so the person comes up with their own unique understanding of their illness and their own unique plan to better manage it. Psychoeducation is a really broad term, and so that is a concept of providing information to people in a way that they can use it to take the information back to their daily lives. So we focus on helping them understand various aspects of their diagnosis, of their treatment options, even things like self-advocacy in healthcare, how to speak up for themselves and become more active in making treatment decisions. It could also be about physical health and wellness topics. It could be things like relationships and setting and maintaining boundaries. So with psychoeducation, we focus a lot on what is this component of managing your illness or managing your daily life needs. How does it relate to your mental health? What are some things that you've tried and how successful have you been or not been? Have you ever heard about some of these other new ways you could try it? And what do you think about those in terms of your life and your values and your resources? And then let's practice some of these skills. So it focuses on helping them understand things and build skills that they can be more successful in. So there's also social skills training. We talked a lot in some of the previous diagnosis specific sessions about the social deficits that can sometimes come with mental health conditions as symptoms of those conditions, as well as sometimes families are really struggling with supporting an individual who is experiencing mental health challenges. Workplaces may struggle to support and understand the person. So social skills training allows the person to develop some of those awareness pieces of their social functioning or challenges, and then how to practice doing some of those interventions. So like I statements and letting people know how you are thinking or feeling, or making requests in a respectful manner. Like we talked before about like learning how to read the room and things like that. And then cognitive remediation, that's kind of a fancy way of basically saying for some of those diagnoses we talked about before, it's things like the executive functioning deficits that some people may have. So this is about helping them find new, maybe neural pathways to get to the completion of tasks that they need to do, or how to provide like visual reminders or prompts in their environments to help them do the things that they need to do. There's also in rehabilitation, like I said, a big focus on physical health and wellness because there's that mind-body connection. So helping people to be physically more healthy in terms of nutrition, activity, hydration, and then things like lifestyle interventions. So that would be things maybe like meditation practices, yoga, things like that. In fact, on one of the inpatient psychiatric units here in town, for all the patients on the unit, the psychiatrist has a standing order that the staff are to provide an evening Tai Chi group to help people kind of power down for restful sleep at night, because just about everybody on the unit complains of poor sleep quality. So he wants them, while they're inpatient, to practice this nightly Tai Chi regimen to see, while they're inpatient, if it makes any difference, and then maybe they'll continue it at home. So that would be an example of a lifestyle intervention. Some of these rehabilitative interventions are done in a group. So even though ACT, assertive community treatment, is an individualized program, the staff meets with patients or clients one-on-one, they may even do some of their interventions in a group, like they may have a substance use group. Or a mental health coping skills group. So people can learn from each other. We have a day rehab program here that focuses on psychosocial rehabilitation. So not only the psychoeducational pieces, but the social pieces, as well as also developing skills, hopefully for like pre-employment as well. And most of the rehabilitation interventions are focused not only on improving skills, but also allowing people to have opportunities to practice those skills in the community. So we want people to practice them in those natural environments or the real world. And one of the things that we do here at Community Alliance is we have community-based rehabilitative services. So that may be in the person's home, or taking them like to the grocery store or the bank, or things like that, to help them practice those rehabilitative skills in real-world settings. Any questions on rehabilitation?
No, nothing in the chat at this time.
Okay. Then in terms of support interventions, these are things that are supposed to help the individual in a non-professional way. So the most common type of support intervention that's provided by peers is like AA or NA meetings, so 12-step type meetings. There are support groups that are specific to mental health conditions. So one of them is called the DBSA, which stands for Depression and Bipolar Support Alliance. There's also NAMI, which is the National Alliance on Mental Illness. There's a group called Recovery International, which doesn't really focus on any specific diagnosis, but it focuses on helping people become more aware of thought distortions and how to identify and recognize those, and then how to correct them. And then there's a mental health support group called Fresh Hope, which again isn't specific to any diagnosis, but it is Christian-based. So a lot of churches will offer these as a way to provide a mental health ministry, if you will, to their congregations. There are also peer support services. So these services are staffed by individuals who have a lived experience with mental health conditions or substance use issues in their own lives. So for an individual to be a licensed or certified peer support specialist, they have to have that personal experience of a condition. They have to be in a sustained period of recovery, and they need to pass a state certification test. So there are classes they can take to do that. There are internships they can do, but ultimately they have to take a certification test to be a certified peer support and wellness specialist. So not only do these members of the mental health workforce, who are peer specialists, understand the obstacles to recovery, both internally and externally from a personal experience, but they also understand treatment and rehabilitation options, usually because they have been in those services or have been around them. And they understand support systems, so they understand how the hospital systems work. They understand how Medicaid works and how to apply for SNAP benefits and where the 12-step groups are that are going to be the most aligned with what that person is looking for in a group in terms of their composition or focus. So they can kind of provide from an insider perspective a lot of information for individuals. They also can provide some help with navigating some of those systems of care, and also just normalize, validate, and support the individual on that journey that they're on for recovery. So whether that's from the very beginning steps to those times that we've all been on some type of journey in our lives, whether it's weight loss or going through school or whatever, and you need like a pep talk every now and then because you feel like you've hit a plateau or a wall. So they can do that as well. And really, one of the biggest things that they seem to do is they serve as a beacon of hope to individuals that recovery can happen and that there is a life worth living on this journey. Because the peer themselves, by being in this active place of recovery and being professionally employed, really is living that truth for the individual. So they can see, if this person's been where I am and they are now in this place, maybe that's possible for me too. We also offer, oh, yep, go ahead.
There's a question in the chat. Is it important for persons in recovery to have a mix of modalities to experience complete holistic recovery? I don't know if you want to kind of give your thoughts about that.
I think that it's hard to say yes, because everybody's recovery journey is unique. And so for some people, they found, luckily, the first time, all of the right things that helped them get exactly where they needed to be. Other people have had a trial and error thing, or they've taken different pieces of different things and kind of made their own recovery quilt, if you will. And so it's hard to make a hard and fast yes or no. Which is one of the things that makes mental health services almost seem more like an art than a science, because yes, there are evidence-based practices, but you can't really say that this is going to help every single person, because it really does depend on so many other factors. Just like, unfortunately, we can't say that any one medication is going to create a drastic improvement for any particular client, because one person may receive an almost complete, perfect response to the medication where they feel almost no effects of those symptoms anymore, whereas somebody else may have catastrophic side effects or may feel like the same medication made them worse. So the same can be said for different types of therapy, or different rehabilitation services. And some of it is even the timing of it too, where the person is in their recovery journey and whether it worked for them at that time in their life. So it's really hard to say. Jeff, what are your thoughts?
Yeah, there's another question which actually goes well with the first one. What are some tips for talking to someone who does not feel that they need mental health services? And I think actually both questions are actually related. One of my thoughts would be, if there's seem to be getting healthier, if their symptoms are less, if they seem to be kind of engaging better with finances and decision making, then I would say they have the right mix of what's in their life. If they are not getting better, if their symptoms get worse, or they, are using substances, or their depression is worse, then that would be a sign that they need some additional kind of resources. And I think a critical piece of this is helping a person to get comfortable with the idea that they may be struggling with a mental illness. And so sometimes there's a lot of resistance we see here regularly of, well, I don't need that. I don't need counseling, or I don't need medication. And I think underneath that is the stigma that says I should be able to do it on my own, the John Wayne kind of mentality. And honestly, John Wayne was an actor, and in real life, some researchers say he was kind of a jerk. So that may not be our best model for how to live our lives. And so empowering people to recognize that we don't say to someone with diabetes or a broken leg, walk that off. They need medical assistance with that. The same with mental illness. And so part of our approach can be helping them to reduce that stigma and to feel safe, to acknowledge maybe they need more help than they wish they did. There's another comment, makes sense, seems like trial and error. Could this do more harm? Is there not a scientific way to determine the best fit for persons in recovery? Yeah, this is an excellent statement. Stacey, do you want to? So
Well,
could
I
do
mean,
more harm than good?
it really is. I mean, it really is trial and error because, I mean, when somebody walks in here, we don't know everything about them. And so we're trying to get to know them, understand their condition to the best we can, because usually the person, because the condition has happened to them and because it affects your brain, it's not like it affects your hand and you can see how it affects your hand. It affects the very center of your body that is perceiving everything and processing and making sense of everything. So if that's the part that's broken, it's hard to really attend and to everything that's been happening to you. So it's very difficult to fully understand the illness because these illnesses also have cycles to them usually, and there's so many things that impact those cycles. So it's really about learning about the person and what their particular patterns and symptoms look like, what's important to them, like what do they value, and how to respect those values and those choices in designing their recovery treatment plans and all of that with them. And then, really trying to help them see that this is a journey. This is a lifelong journey. So this isn't a one and done. You're not going to, we're not going to find the right combination of medications and you'll be perfect forever. We hope so. But we have to anticipate that there may be some bumps down the road too, where we'll have to recalibrate things. But giving them options, helping them make decisions, and hopefully, bringing in the people that are important to them too, to understand why the person made those decisions, what we can do if those initial plans don't work. Like Jeff, you said, kind of how will we know if they do or don't? And then if they don't, then what? Kind of like, in cancer treatment, if the first drug doesn't get the person in remission or cured, you try a different approach. We sometimes have to let things kind of play out for a little bit to see. What we'll get to, I think maybe in the next slide or two, also is a bit of a discussion about how to put all that together, because you can throw absolutely everything at the person all at once and hope that throwing everything at them, wrapping everything around them tightly, helps get things really a lot better, really a lot faster. And it may do that, but it may also overwhelm the person. And so sometimes more is better, sometimes more is just more. And so we have to make that decision with the person too, about based on what we know about them and everything going on in their life and where they're at in their mental health journey, and what resources they have available to them. Do we really want to integrate all of this care around them from medications to therapy to primary care to substance use treatment and day rehab, and maybe they're in a residential group home. We have all of those services. We could put all of those things around them. We could throw peer support in there and all kinds of other things. But sometimes more is just more, and more might be overwhelming and stressing the system even more than just starting with some medication and then adding some therapy, or, so kind of phasing things in versus here's a 100-step process that we're going to go through.
Yeah. Stacey, there's another question I think is relevant too. How do you measure response to community support interventions and feedback? Do we use like patient voiced positive aspects and experiences? And I think it's an excellent question. And I think that's why the feedback from resources in the community is so critical, that we, believe it or not, therapists sending a letter to the judge saying this is what the person's been working on, and or they refused to come in for treatment, or they completed this many sessions. So while that is more work to coordinate care, I think having multiple feedback loops is a critical part in understanding whether a person is taking the resources and engaging them, or if they're struggling. We do know that doing nothing with bipolar disorder and schizophrenia is going to result in continued symptoms. So we do know that certain interventions are required. Which ones and how they work is an art. And I think getting client feedback and then feedback from the resources is critical as well. I don't know if you have anything to add to that.
Well, and some of what we do, particularly in like some of our rehabilitative services, is we look at their functional skills. So we have a tool that we use to assess their functional skills every 90 days. And that's one of the things that we look at to see, are they getting better functionally? Because if they're getting better functionally, there's probably something underneath that that's allowing them to get better functionally, which is their symptoms are more manageable. And so we look at that. The doctors and therapists often will have the person track how they're feeling. So some of it can be things that you can kind of quantify, like how many hours of sleep you got, but some of it could be like mood charting and things like that, where you could see like, how high was my anxiety today, or how low was my mood? And if you can look at that, over the course of, a month or over the course of a year. In fact, symptom tracking, this is a long time to do it, but symptom tracking over 2 years has been shown to like reveal patterns that just tracking it for a month may not. Although for some people, tracking it for a month gives them some indicators of things that might be peaking their symptoms. So things like, for women, it could be like hormonal changes within the month. For anybody, it could be things like financial stressors. So if they live on a fixed income, or even those of us that don't necessarily live on a fixed income, but, maybe things are a little tighter the closer you get to payday. So that stress may increase the person's symptoms a little bit. So symptom tracking can also help the person see patterns and then try different things to get better. And so like if the doctor or therapist is having them do that, they can show them that like 3 months ago, your average daily anxiety score was a 7 and now it's a 4. That's better. So those are some ways to kind of measure outcomes as well. But there's a lot of subjectivity to it too. So now another thing I wanted to point out on here too is family education. And this can be really important specifically for the Thrive Court, I think, because you've got families that are involved. And some of the parents may be struggling with mental health issues. Some of the children may be struggling with mental health issues. Family education, it provides services to, they say families, but it's really to any natural support system that the person has. So it could be blood relatives, it could be significant others, it could be sponsors, it could be clergy people that are very connected to the individual. It could really be anybody, a neighbor that's very supportive of someone. But what it does is it provides a way for that that support person to get some information, so some psychoeducation for themselves about what mental illnesses are and aren't, so dispelling some stigma. Also things like what treatment and resources are out there, because nobody is really like given a handbook on that. And then also how to level up their skills. So I think one of the questions was about how do you have these conversations? In the class that we teach here, it's an 8-week class for families, and we focus a lot, and we do this individually with families too, in coaching them. A lot of basically motivational interviewing with clients, kind of the lay person's, it's a therapeutic tool, but you can teach it to anybody. So where you really seek to kind of understand the problem from the person's side, or understand the symptoms from the person's side. So how to have those conversations and not necessarily just escalate right to control or authoritative approaches, kind of yes, you will, no, you won't kind of thing, as well as how to empathize with what it feels like to experience the symptoms that the person is experiencing, and then how to problem solve, because we've probably all had this experience in our lives where, especially if you're a parent, where your children are making decisions, and when they're adults, they get to do that, and you know that it's a train wreck coming, but you can't solve the problem for them. All you can do is solve the problem of how am I going to be okay with them making this mistake. And so they do some of that as well as, and then also in family education, they focus on how to take care of yourself as a caregiver so that you don't burn out, because that's a reality that happens. And so kind of that put your own face mask on first on the airplane. You've got to do that too. Okay, so the next thing that I wanted to talk about, and why is my slide not advancing? Okay, where's it going? My slide is not advancing to the next one. But one of the things that I wanted to talk about here is, there we go, is how we can use this information that we've talked about today to help the people like that are in your courtrooms. So let's put this in context of what we've already learned so far. And looking back to our first session, we talked about genetic factors that sometimes go into the development of mental health conditions. We also talked about adverse childhood events. We talked about the stress vulnerability model and activating symptoms. And so we talked about all of those things, as well as the trauma that people experience, and in some cases, the generational aspects of their stories. So that, these things have happened for generations in a row, and this is just kind of the latest iteration of it. So for many of the people we see here, they may also be served by public health systems or involved in criminal justice. There are genetic and generational issues that are involved. And life is hard and messy and stressful too. So the current stress that is going on in people's everyday lives exacerbates the severity of their symptoms and decreases their functional abilities. So I want to just make sure that, we're really thinking about all the strain that people are under, particularly when they're in your courtroom. So sometimes what we're asking them to do is a lot, given all the other things that are going on in their lives, like how many people are in their house, how stable their housing is, what their cultural background and values are, their gender, whether they are, a single woman or, a married man, their employment status and how stably they're employed, and the demands of all the things we're asking them to do on their livelihood, as well as how educated or literate they are in the law or mental health or anything like that, how stable their finances are, what supports they have in their life, and how physically healthy they are as well. And then things like transportation issues also. So when we're thinking about those things, we want to be part of the solution. The whole reason you have Thrive Court, the whole reason there's mental health diversion courts and drug courts and all that is because we really want to be part of the solution for people of getting them to a better, healthier place rather than being penalizing and incarcerating people. So, are there ways that we can streamline and integrate services like having all of their appointments on the same day or back to back or on one site so that they don't have to, rush around and do all those kinds of things? What about navigators? Is there somebody, maybe like a graduate of the court or a peer, who can assist in coordinating services, explaining processes to people, and then helping remove or address any barriers that they have? And then assistance with material needs, like do they need gas vouchers or transportation supports to get to the things that we're trying to have them do? Do they need food support? Are there childcare services that are needed so they can participate in the things we're asking them to do? And then are there other supports that can be provided to them? Some people may or may not have their own good support system in their lives. So maybe other families that are in the court program that are going through similar things, or graduates of the program, or getting them connected to some of these community-based mental health supports. And then scheduling considerations. So like here, we provide an evening clinic each week. So people who need services, whether it's primary care or mental health and counseling services, can get that in the evening. So is there a way, even if it's once a month or once a quarter or whatever, that you could have an early morning before school or before work, or an evening, court time where, maybe it's at 6 or something. So people don't have to leave work again, or don't have to take kids out of school again for some of these things. Any final questions, comments, anything at all?
So you said there was a question about the family education services, and I just linked it out in the chat that we have a family-to-family program that's right now it's free to the community. It's probably more of just an access issue and capacity, but people are welcome to call our main number. And I know there's family education in other agencies as well.
Mhm.
All right. Well,
All right.
thank you, everyone. I think the certificate is on the chat right now. If anyone needs that for their record. Thanks for joining us. Thank you for this presentation. This was very helpful. Our next session is December 3rd, and the topic is building healthy supports. So thanks, everyone.
Thank
See you in December.
Thanks, everybody.